We will talk about Surviving Sepsis Guideline 2026. Last Surviving Sepsis Guideline was published in 2021, and there are some amendments in this guideline which I have written in this purple color, while the existing guideline in 2021 I have written in the green color that was not changed. So total important 6 points they have discussed sepsis guideline. The first is screening, second is the initial resuscitation, the third is the control and the treatment of the infection, the fourth is hemodynamic goals and resuscitation, the fifth is the ventilation parameters, and the sixth is the additional therapy. You need to remember only these 6 points only. The topic can be asked in 10 marks question, as well as the sum of the questions from this thing is asked in Viva also. So let's start with the screening. In screening, they have the initially the Q SOFA was important. Now in 2021 guideline they have removed the Q SOFA and introduced SIRS, News and Muse. So prefer SIRS, News and Muse over the Q SOFA. And in recent guideline 2026 they have introduced the News and News 2. Apart from this, they have used the word cord sepsis and sepsis hurdle. So they have told that the word cord sepsis or the sepsis hurdle, which is the alarm like the cord blue as the similar, and you raise the cord sepsis alarm and you start the following this initial resuscitation protocol. You should not rule in or rule out based on the single biomarker or the test. This is the screening part. Now, there are multiple points in the screening part, but I have covered the most important and the most clinically significant part in this lecture only. Now, the initial resuscitation. Initial resuscitation, the sepsis is a medical emergency, and the treatment should start immediately. You should send the blood culture as soon as possible and before the administration of the antibiotic. If the shock is present, your target to give the antibiotic should be less than 1 hour, and target for the ICU admission is less than 3 hours. If the shock is present, give crystalloid at least 30 ml per kg. Your target should be more than 30 ml per kg in first 3 hours. Let's say patient is the 60 kg weight and you are giving the 30 ml, you should administer 1800 ml of the fluid in first 3 hours. Then after this first 3 hours of the 30 ml, more than 30 ml per kg, you start using the lactate, you start using the capillary refilling test or the dynamic measures to guide your further fluid administration. And if your shock is not controlled with this fluid, you add the vasopressors. And in recent guidelines, they told you start vasopressors peripherally. Don't wait for central line access. Okay, your target BP should be 65 mmHg plus minus 5. If the patient is of more than 65 year of age, your target BP is 60 to 65 mmHg. This is your initial resuscitation. Now, after you have screened with the SIRS, News, Muse, News 2, News and News 2, you have raised the cord sepsis and sepsis hurdle, you have initially resuscitated patient, you have sent the culture, you have given the antibiotic within 1 hour, you have admitted the patient in the ICU, you have given the fluid adequate in the first 3 hours, more than 30 ml per kg, and you have maintained the blood pressure of the 65 mmHg of the MAP. Now you control the infection. This is the most important and the most lengthiest part of the sepsis management. If the shock is present, you give the antibiotic within the one first hour of the recognition. Now the new part, this 2026 guideline is this one: pre-hospital antibiotic in the flight or the ambulance if the transit time is more than 60 minutes. If you feel the patient is in the ambulance or in the flight, if you feel that the admission time, reaching time till to the hospital is more than 1 hour, you start giving the antibiotic in transit only. If the shock is not present, you do the rapid assessment of the cause or the source and give the antibiotic in less than 3 hours. If you feel that there is the low likelihood of the infection and there is a no shock, I mean the patient is stable and there is no evident infection is there, so wait, defer the antibiotic and do the close monitoring. You should continue re-evaluation and screening for the alternate diagnosis. It is not like that on the first side you have decided and stick on that thing. No, daily you should continuously re-evaluate where is the source, is there any other source, is there any other cause, is there any alternate diagnosis. If you find that yes, there is alternate diagnosis or there is alternate source, discontinue antibiotic on your primary assumption and when the alternate cause is demonstrated. Now, procalcitonin should be used for discontinuation of the antibiotic, not for the starting of the antibiotic, not to be used for deciding when to start the antibiotic. Don't start antibiotic based on the procalcitonin. Use clinical evaluation alone. Clinical evaluation alone should be your deciding factor to start the antibiotic. Procalcitonin with clinical evaluation, both should be combined to decide when to discontinue antibiotic. High risk of the MRSA. High risk of the MRSA, if you feel that the infection is there and the neighbor nearby patient is having the MRSA and this patient must be having the MRSA, then you start without you start the antibiotic according to that MRSA. That was in the guideline of the 2021. Now in the recent guideline they have removed this part of the MRSA. Instead they have administered another para, which is this: without risk factor of the anaerobic infection, you give the empiric antibiotic without the anaerobic coverage. And if you feel that there is a with specific risk factor for the anaerobic infection is present, which are the specific risk factor for the anaerobic infection? It is this: it is the obstetric or gynec cause, or the necrotizing tissue infection, head and neck infection, CNS sepsis, empyema. If this cause is present, there is a high chance of the anaerobic infection, and in this case you give empiric antibiotic with anaerobic coverage. Now, multi-drug resistance. If there is prevalence of the high risk of the MDR, you give the empiric antibiotic that covers the MDR. If there is a low risk of the MDR, do not give empiric antibiotic which is having MDR coverage. Now, empiric antifungal, it is removed. No need for the empiric antifungal administration. In previous guideline, there was written that if there is a high chance of the fungal infection, give antifungal. Low risk of the fungal infection, do not give. But in this guideline they have completely removed the antifungal. No need for the antifungal. Candida biomarker is also not advised. In antifungal you should administer only in that case which is the highly susceptible for the fungal infection, like the long-term ICU administration or immunocompromised patient. Antiviral is not required at all over here. Now you identify the anatomic infection like central line, cannula, or urinary catheter you have administered. Promptly remove it. Identify the anatomic source. Is there any abscess, any sepsis, any cellulitis, and early rapid source control within 6 hours is advised. Prolonged infusion of the beta-lactam for the maintenance over the bolus. Then on the mechanical ventilation patient, the patient on the ventilator used SDD. SDD is the selective decontamination of the digestive tract. If the source control is adequate, use the short-term antibiotic. You feel that the adequate source control is there is no other source of the infection, you have given the antibiotic according to the culture reports, use short-term, not long-term. Now, this is the 2 points which are recently admitted, that use pathogen-specific rapid diagnostic test, which is cash to cash basis, not for the all patient, and the target the therapeutic drug monitoring also in the selected patient, not for all patient. Now, the fourth point is the hemodynamics. How you control the hemodynamics? Crystalloid is the first line drug, not colloids, crystalloids. You should use crystalloid for the resuscitation of the patient. Albumin is used only for the patient who have received a large amount of the crystalloid or the cirrhosis. Okay, but in like in the patient with the sepsis with the traumatic brain injury, in traumatic brain injury, you use the saline 0.9%. You should use the dynamic measure, stroke volume variation, pulse pressure variation. You use the serial lactate measurement to guide your fluid administration and fluid resuscitation. First line vasopressor is the obviously noradrenaline. Everyone knows, if the shock is present, you have given the noradrenaline and still the MAP is less than 65, you use the vasopressin. Still hypoglycemic, you add the adrenaline. This is the standard practice all are following. If the patient is with cardiac dysfunction, you can add the dobutamine. In previous guideline, invasive monitoring was recommended, but in this guideline, they have told invasive / the non-invasive monitoring. You start the peripherally vasopressors, don't wait for the central line. So this is the hemodynamic part. The fifth part is the ventilation. Ventilation, there is sepsis-induced acute hypoxemic respiratory failure. Acute hypoxemic respiratory failure is obvious in patient with the sepsis. First choice is HFNC, high frequency nasal oxygenation, over the non-invasive ventilation. Now, sepsis induced ARDS. The patient, if once went into the ARDS, your target is lung protective ventilation, like the low tidal volume 6 ml per kg, plateau pressure should be less than 30 centimeter H2O, and the high PIP. If the patient is not intubated, you prefer awake proning. Patient is awake, you make the patient prone, and the daily proning period should be more than 12 hours per day. Traditional recruitment maneuver is recommended. Traditional recruitment maneuver, not the fancy protocols like the incremental PEEP strategy, vagera. You do not use this incremental PEEP strategy. Use the traditional lung recruitment maneuvers. Neuromuscular blocking agent in the ventilated patient, intermittent is preferred over the bolus. Intermittent bolus is preferred over the continuous infusion. ABG is the gold standard, as we all know. SpO2 by SaO2, PaO2 by FiO2 is recommended to measure. Target SpO2 should be 90 to 96%, not less than that, not more than that. Now, additional therapies to look for in patient with sepsis in ICU. If the patient is on the shock and ongoing the vasopressors, you add corticosteroids. This helps in the early recovery. Now, the blood purification therapies like hemoperfusion, hemofiltration, plasma exchange is not recommended. Do not use any blood purification therapy, no benefit of it. If risk of the GI bleed is present, do stress ulcer prophylaxis with the PPI. You administered VTE prophylaxis like the LMWH over the UFH. Mechanical prophylaxis is not recommended in the patient with sepsis. If the AKI is present, you intermittent or continuous renal replacement therapy, but do not use acute fluid removal, because there is a hypotension, patient will die because in acute fluid removal. So do not use the hemodialysis. Use renal replacement therapy slow. Insulin, to give insulin if the glucose is more than 180 mg percent. Do not use vitamin D, vitamin C, probiotics, or soda bicarbonate. There is no benefit but the harm. Soda bicarbonate is only indicated if the pH is less than 7.2. Until 7.2, do not administer routine soda bicarbonate, and do not do active surface cooling to reduce the temperature. There is no benefit. And early enteral nutrition should be given in less than 72 hours. So only this 6 point you remember. Your surviving sepsis guideline 2026 is well covered in this topic. There is no any point pending in this 2026 guideline I have covered in this thing that is important for this exam point.